Because on the one hand, like I was saying, you don't want to over or misdiagnose, but on the other hand, you don't want to leave things too late, right? So there's that really careful balance. I don't mean too late. Obviously, there's no too late. Like we can always come in and intervene and help. But I mean, when there's something that is actually then quantifiable and we can be intervening, we don't want to leave it, we don't want to leave the child struggling unnecessarily.
Every ADHD child brings their own set of challenges and strengths. But how do their personal traits mesh with cultural and social influences to shape their diagnosis and support? And what can we gain from recognizing these early on? Today, I'm chatting with Drs. Yael Rothman and Katia Fredriksen, neuropsychologists and authors of the Different Thinkers book series. They'll shed light on the subtleties of diagnosing ADHD, the untapped strengths of these kids, and the importance of comprehensive neuropsychological assessments. All of this and more straight ahead on episode 223. I'm Emily Kircher-Morris, and this is the Neurodiversity Podcast.
What is neurodiversity? You see the world differently.
Autism spectrum.
Gifted.
Complexities that are inherently inside.
ADHD.
Dysgraphia.
Tourette's.
All brains are different.
You are exactly what this world needs.
This is the
Neurodiversity
Podcast.
Don't forget about the continuing education courses we have available on the Neurodiversity University online learning platform. From supporting twice exceptional students to understanding dyslexia in the classroom, we have a range of modules and courses that you can take on your own time. Each includes a certificate of completion and offers valuable strategies that you can put into action with the neurodivergent students in your class. Just hop on over to neurodiversity.university to learn more. Okay, Dr. Rothman and Dr. Fredriksen are here next.
previously on the Neurodiversity Podcast.
One example that crossed my mind was from my own neurodivergent autistic daughter, who's 25. A couple of years ago, we were talking about Christmas, and she said something about the hardest part of Christmas morning. And I said, what are you talking about? What's hard on Christmas morning? That's just fun. And she said, you know, when you open a present and you have to remember to put a happy face on. And I said, do you mean like if you don't like the present, you don't want to hurt the person's feelings? She said, no, even if it's a great present that you love, you have to remember to put the happy face on. You know what I mean? And I said, no, I'm not autistic, by the way. No, I don't know what you mean. Like for me, my face just does what it's going to do. And in moments like that, I don't have to consciously put a happy face on.
That's episode 216. Find it wherever you get your podcasts.
Today, I'm talking with Drs. Yael Rothman and Katia Fredriksen. They are neuropsychologists who assess children and teens for a wide range of learning and developmental diagnoses, and they are also the authors of the Different Thinkers series of books for elementary-age children to better understand their own diagnosis. So before we start, I'm going to have each of you introduce yourself so people can kind of identify your voice. So Dr. Fredriksen, why don't you go first?
I'm Dr. Fredriksen. It's a pleasure to be here. Thank you for having us.
Hi, I'm Dr. Rothman. We are very excited to talk with you today.
So we're going to focus our conversation today on kids with ADHD and what we really need to know in order to best support their needs. And there are just so many factors that really influence how signs of ADHD manifest, whether that's a kid's personality or their personal strengths and difficulties in areas that are even outside of executive functioning. But I actually want to start off and talk a little bit about some of the cultural and socioeconomic factors that influence how ADHDers are supported. So I'm hoping that you can share some of the ways that you notice those factors influence how kids either receive or don't receive a diagnosis, and then also how it's really managed.
Well, we know that a higher proportion of white children are diagnosed with ADHD, despite the fact that there may be similar ratings of symptoms in different groups. And Latino and Asian children tend to have the lowest rates of diagnosis, but that doesn't necessarily mean that they don't merit similar rates of diagnosis. There are lots of different factors that can play a role. On the one hand, it's interesting because, you know, what I've just said seems counter to another piece of information, which is that the higher a family's income, the lower the likelihood that ADHD will be diagnosed. And this is true for all racial and ethnic groups. And so the possibility is that there are groups of children who are either being missed or who are being diagnosed inappropriately. So there may be, so for example, if a child is living in a high stress environment, if they're not sleeping enough, if they're not, they're just not ready for that transition to kindergarten, first grade, there may be misdiagnosis, right? And in other children, we may be just altogether missing, as opposed to misdiagnosis, but just missing the diagnosis that is in fact there. And then, as you alluded to, this can also affect sort of treatment in terms of, who's getting appropriate intervention and who isn't. And a lot of that accessibility to information and consistent medical care is affected as well. So lots of variables to take into account really in this regard.
I think it's also important to think about how different cultures will have stigma that might be associated with a diagnosis. And there may be some where it is less stigmatized and then some where it's highly stigmatized. And we've definitely dealt with that in our offices where we work with families from different cultural backgrounds and see some where it is immediately accepted and understood, and they have friends and relatives to understand the diagnosis, and then others where mental health is not a part of accepted culture in general. So I think that's also a really big piece here, because the diagnosis very highly relies on the family in this case, for almost most of our diagnoses that we give. But for neurodevelopmental, we do a lot of interview with family to understand that.
If families don't even know to seek help, or they don't have the cultural capital to know how to seek that help or where to seek that help, or if they just don't have access to the providers who can assess, and all of those factors really influence whether or not a kiddo gets identified and gets help.
Very much so.
There's also a real benefit to identifying ADHD early and intervening at a younger age. But I think there's so much stigma surrounding ADHD that many families, educators, practitioners hesitate and often want to take a wait and see approach. What are your thoughts about where the balance is there? How do you decide when is the right time to seek a diagnosis and then determine how you're going to treat it?
I think a lot depends on having a good understanding of what's sort of within the normal range of development, because a lot of the characteristics associated with ADHD are completely typical at certain ages. And we don't want to pathologize something that is in fact just part of the normal process of development. And so that's really critical. And so a way to assess that is, via clinicians, pediatricians, et cetera, who have that understanding of child development, and via accessing standardized questionnaire data, whereby you can compare to other parents of 6-year-old boys. This kid's parents are reporting a really high rate of whatever the concerning characteristic is, especially in that sort of 5, 6, 7, and especially among boys. I just think you always want to be really cautious that you're not overdiagnosing, or maybe you just need to be, sometimes you'll provide a rule out or a provisional diagnosis just to sort of be 100% sure. Because on the one hand, like I was saying, you don't want to over or misdiagnose, but on the other hand, you don't want to leave things too late, right? So there's that really careful balance. I don't mean too late. Obviously, there's no too late. Like we can always come in and intervene and help. But when there's something that is actually then quantifiable and we can be intervening, we don't want to leave it. We don't want to leave the child struggling unnecessarily. So there's that fine sort of line there, that balance where you really need the benefit of that understanding of what development typically looks like.
True. You were talking about why early diagnosis intervention is so helpful. And I think when we can intervene from a younger age, it really does help with the destigmatization as you get older, because it's always been a part of you. It's always been your story. You learn how to advocate. Less negative feedback might happen because people understand your profile and you understand your profile better. So there's a lot of benefit from hearing about this at a young age. But I think Dr. Fredriksen has some really wonderful ways to talk to families instead of the wait and see approach.
Oh, well, good.
Yeah, I love it. Is you talk to a family and say, listen, if these are your worries, put a date in the calendar a few months from now and check in with yourself. Is this still going on? So now it's not a wait and see, it's more of a check-in. Like there are structure, you're thinking about it. It's not just, oh, that was a hard time back a few weeks ago. You actually are taking data. And I think that that can be so much more helpful to make it more structured and understood that way.
What age do you think is appropriate to assess for ADHD, and how do families decide that that's something that they want to or need to pursue?
So this is going to be so variable. If there is significant challenges, a child with ADHD can get a diagnosis very early on in their life. That's not usually the population that Dr. Fredriksen or I would see, but I have known of individuals who are diagnosed at age 3 or 4. That's just so unusual to hear about. As you move on, usually the school age is what would be more common, that transition to first grade where you start to see how complicated it is for the young person to be present, focused, or stay seated for that longer period of time and throughout the school age experience. Those are the most common individuals, I think, who come into our office are the school-aged kiddos.
Yeah.
Just cycling back to that idea of the racial and the socioeconomic factors we were talking about earlier, that idea of being ready for school, right? And just taking that care there in terms of some kids have never attended a school environment before they start kindergarten. Other kids have been in a structured environment since they were infants, right? And so just in terms of the exposure the child has had to environments that have those same requirements. Again, what's the sleep situation at home? Is there a trauma history? These are all things that we want to be looking at to be sure that we are barking up the right tree. If we see an issue, is it ADHD or is there something else that we can help with?
That's really important. And that's why it's so individualized. We have to understand the child in our office. What has their life experience been?
What are some of the longer term benefits of having that early diagnosis as opposed to kind of taking that wait and see approach? Like, what do you find are the interventions that families can access or that practitioners can use that have a cumulative effect as time goes forward for kiddos?
Well, we always recommend, based on what's supported empirically, that first tier consideration is the possibility of medication. Right. So we always recommend that parents consult with their pediatrician or a similar sort of medical provider about that possibility. Excuse me. And then we always just wanting to come at it from lots of different angles. We think about what might be helpful for the child at school in terms of accommodations, and what might be helpful at home in terms of parenting strategies that can really help the child navigate some of the tasks that are more difficult. In such a way that is also less frustrating for the parents, because we know that it can be it can be a struggle for all concerned when a child is not functioning there are certain things a child is not doing that parents expect, possibly reasonably, possibly unreasonably, but just so what are strategies that we can put in place to help the child do as well as they can and the parents also do as well as they can.
Mm-hmm. One of the long-term benefits of an early diagnosis could be the self-esteem of the child then through these situations. Like instead of getting that negative experience early on, they are aware my brain is different. I need X, Y, and Z to support me. And that can build their self-confidence and self-esteem. And also like what Dr. Frederick was saying, like the mental health of the family system as well. So they can understand, oh, let's replace our words. It's not lazy. It's not bad. It's not wrong. It's different.
Mm-hmm. Yeah.
And something we can work on.
We know that girls are diagnosed less frequently. And I would love to hear your thoughts about what some of the reasons are for that.
Yeah, it's 100% true. Boys are diagnosed with ADHD almost twice as often as girls, but research is suggesting that it affects boys and girls at similar rates. So what's happening, girls are being not being identified. And one common reason is that the more common presentation of ADHD in girls is the inattentive presentation. So people sometimes refer to that as ADD. Really, people might know that we call it ADHD, predominantly inattentive presentation. And this is an individual in the classroom of 30 who might go missed, right? If you're in the classroom, you have a teacher who is teaching all of these young children, the squeaky wheel gets the grease. The children who have more hyperactive impulsive presentation are probably the ones that are going to be noticed at that time. The quiet individual who's sitting at their desk and daydreaming probably is not going to be as apparent. Usually those girls come to us later on in life when the executive demands have like exponentially increased. You're getting into high school even maybe sometimes, and they're so lost that they can't manage the demands of homework and extracurriculars and studying for the SATs and all these different things that are going on. And we start hearing about the pattern. Oh, you always got by because you were so smart and you were able to not pay attention and be present there.
Yeah.
A lot of times girls also get misdiagnosed with anxiety or a more mood related diagnosis. They attribute the inattention to emotions versus inattention to ADHD. So then what do we do about this? I guess first we'd love to educate and hope that other people will be educated about this as well, that we think about differentials. What's going on here? Could it be anxiety and inattention? Could it be just inattention and not a anxiety related piece? And learn about that a little bit more in our girls. Asking questions about the young person's experience. If you're having to reteach everything to your child at home that they learned in the school day, that's interesting. Why weren't they present for that day? And to find out more there and talk to teachers. We really tell families, if you have a question, ask it. If you have a worry going on, find out a little bit more. That's okay. It's always okay to ask and find out more.
Mm-hmm. Can you elaborate a little bit on how you tease out the differences between inattention and anxiety?
I would say a lot of thorough interviewing is going to be there because they don't have to happen without each other. A lot of times they're very much connected. Our emotional and our executive systems are often intertwined. And you don't need a diagnosis for this to be true. If you're thinking about, I always give the example, like doing your daily grocery shopping, but you're hungry or upset or angry or tired, you are not going to have as strong executive skills. You might spend twice as long at the grocery store because you're going up and down the same aisle. You might leave without the thing you meant to buy because your mind is elsewhere. You might get impulsive at checkout and get the chocolate bar, which is why they put it there, right? Because they know that people will do that. And they really weigh on top of each other. So when anyone is worried or anxious, they're going to not be completely present and attentive. So can we separate them completely? Not always, but can we say, do you have all the criteria for a diagnosis versus is this coming from an anxious place?
And I tend to think just there's a bidirectional causal pathway there. I mean, if you think about it just from common sense, you are a kid in the classroom and you suddenly realize you have been staring out the window for the past few minutes and everybody's getting up to do something and you don't know what's going on. That's going to make you anxious.
Sure.
And vice versa. If you're sitting there in your seat ruminating about, well, they didn't let me sit with them at lunch today, maybe they don't like me, you're not going to be paying attention to what's going on, right? And so it makes a lot of sense when you just think about how that could play out in a day-to-day type situation. And then it becomes a question, like Dr. Rothman was saying, about figuring out what's primary, what might be the main underlying piece, and what is secondary.
Mm-hmm. That's the kind of exciting part of our jobs, right? Is that we are detectives and we kind of figure out where are things coming from, because there is such a huge overlap with so many childhood conditions. And that's that's our job.
I find that, as a clinician who works with kids and teens, part of the other compounding factor that makes it more difficult with kind of trying to tease some of those things out is that kids are not always great at self-reporting. Like they don't always have as much knowledge or as much insight based on their life experiences. They might not really have the ability to kind of reflect on what they're experiencing. But I also think that that's something that then influences parents. Mm-hmm. So for example, we were mentioning medication. And I think that it's so hard for parents to decide whether or not they want to try medication for anything psychological in nature. They're worried about what impact that's going to have on their kid. They're worried that their kid's not really going to be able to verbalize perhaps how they're feeling or if they like it or if they don't. I mean, maybe they will. It's much easier as an adult to go, yeah, I'm going to try this. And then maybe I'm, I'll know if I want to continue it or not. How do you approach that conversation? You mentioned, Dr. Fredriksen, that medication is a really great option for a lot of kids. How do you handle that conversation with parents who maybe are a little bit hesitant or cautious about using medication to manage some of these symptoms?
Right. And that, as you know, is virtually sort of every parent to whom you present the recommendation, right? And as parents ourselves, I'm sure we understand that. I tend to fall back on research to present this as something that, so these medications have been around for a long time, and they've been used in children for a long time. This is no fly-by-night kind of scenario. There's a lot of long-term data on efficacy and safety that is not necessarily available with other medications that children are put on, right? So there's a lot to fall back on there. To my mind, it's sort of a cost-benefit analysis. The vast majority of parents are not eager to medicate their children. So then it becomes a question of, well, what's the potential cost of not doing it? And so we sort of think about my barometer that I tend to ask parents to consider. There are three things I think about. One is, are the symptoms in question affecting the child academically, right? So is the child falling behind or struggling to develop core skills because of, for example, the attention problem? Number two, are the symptoms in question affecting the child socially? So if you have the kid who's always poking other kids and cutting in line and calling out, is that child starting to experience rejection or bullying, exclusion? That would be another factor that I would think carefully about. And then the third is, how are the symptoms in question affecting the child emotionally? And that's linked to the two previous things I just mentioned. So are we starting to hear I'm just no good at X, or I'm just not smart, or whatever it is? Are we starting to hear those sorts of things? And then to my mind, when we've ticked any of those boxes, we've started to hit a tipping point. And again, everybody's going to be different in terms of their comfort level. And obviously, given that this is our field, we have a greater comfort level because we talk and think about this every day, which most parents don't. But when you've sort of ticked any of those boxes, that's really when a tipping point starts to come to mind for me. And so I try to just educate parents about what the nature of the medications are. And, we're not MDs, but we certainly learn a lot about this through the process of our training and our clinical experience. What are the potential benefits? What are the potential side effects? How would a trial work, et cetera? And then I encourage them to consult with their pediatrician to learn more about it. And I give them different things to read, websites, books, et cetera. Again, comes down to that cost-benefit analysis for me, and families may make different choices or have different views of that.
It's a hard decision.
Mm-hmm.
I want to kind of shift a little bit, and I want to talk about, from this neurodiversity affirming perspective, and really recognizing while ADHD can have some difficult aspects to it, there are also a lot of strengths and positive attributes that a lot of ADHD brains have. So what are some of the things that you notice that we can leverage to help ADHD kids be successful?
Definitely. There are so many gifts that come along with a different thinking profile. For ADHD, we know that research has shown higher creative thinking, that they are more out-of-the-box thinkers, creative thinkers. And that might be why there's a high number of CEOs who identify having ADHD. We know in ADHD, even though it's called attention deficit, there's also variability. So you can hyper focus on areas of interest, and focusing on preferred topics actually can be really helpful later on in life in career options and career choices. There's been some athletes who have talked about that with their ADHD and how that's actually made them get to the Olympics because of their hyper focus on a specific sport. The willingness to take risks can actually be a beautiful thing, right? It being a risk taker can have some downsides at times, but also can be a really great thing. Resilience is a big piece in many different thinking neurodiverse profiles. In ADHD, the abundant energy and spontaneity also can lend itself to beautiful gifts and not just, oh, you are hyperactive. Actually, that energy can be a great thing as well. So understanding where those gifts lie and telling the child about this when you're talking through these things can be so great so they can understand the positive attributes that go along with it.
What I really hear you saying, though, in many of those examples that you give, is that in order to really foster and nurture those strengths, we have to find an appropriate environment that's a good fit. Because I feel like when you're talking about whether it's that hyperfixation or, an industry that they're interested in, or what those creative pieces of thinking, like being able to be in a place where you can show those and feel successful with those has a lot to do with how that child then interprets their own self-worth, their own self-concept, to be able to see that those strengths really are effective for them.
Again, that's where sometimes we come in to advocate or educate school providers, other people about how if you have one rigid idea of this is success, how that's going to leave out so many in the room, and how we can support and accommodate those who need it.
Thinking about these strengths, thinking about these positive attributes, and then thinking about how we have these conversations with kids. This is all something that has led you to launch your book series, Different Thinkers. And so the first book that's out is all about ADHD and about talking to kids about ADHD. So before we talk too much about the book, though, I would love to ask you, what do you think the value is in having parents or clinicians or educators or whoever talk to kids about their diagnosis? How should they broach that topic directly on and just say, this is what it is, and give information? Is there a different way to handle that conversation? What are your thoughts on that?
Well, it's interesting. It's an evolution of our field, really, because many of us were trained more stringently in how to give feedback to parents or other caregivers, potentially to schools, but many of us were not trained in terms of how to actually present the information to our client who is below potentially the age of an adolescent. And so I think that that's just in recent, maybe even in the past decade, is when it's really started to flourish, this idea that sort of kids deserve this information too and can handle this information too, right? I think a lot of us have become, we realize that kids are so much more aware than we realize at times, right? And they will very often have noticed that there's something that is maybe a little more difficult for them or a little different or whatever it is. And unfortunately, then how human nature works is we tend to sort of think quite negatively about things. You hear kids, saying negative things about themselves, negative self-attributions. We alluded to earlier the sort of the I'm not smart, the I'm not good at this, or I'm not as likable as so-and-so, or whatever it is. And so we think it's much kinder and more accurate for the child to have an actual understanding of, oh, well, guess what? All brains are different. Based on how I function, I'm really good at XYZ, but ABC is a little harder. And here's what we can do at school, at home, etc., to help me build those skills or to help me sort of bypass those hurdles. And so just this idea that in the context of attention, I'm having to work X amount harder than the average kid in my class to pay attention or to sit still or whatever it is. And it's not my fault. It's just how I'm wired. And here are some things like I can use fidgets or sit on a wiggly chair, or maybe I'll take a medicine, or maybe we'll be sure that I'll sit in a certain spot in the classroom, et cetera, et cetera. So that's really what brought about the idea of our book series, because we will sometimes do student feedbacks with little guys I routinely do them with adolescents, sort of middle school and up, and then I offer to do them with younger kids, and sometimes parents will take me up on that, and sometimes they won't. When I'm doing it, or when I'm advising parents on how to do it, I tend to sort of say, well, you have a couple of options in terms of how you're going to present this information. I mean, so number one, if they've just, for example, had an evaluation with us, you can say, hey, guess what? Remember when you saw Dr. So-and-so? You did really well. Like I said before, you did really well at these things. Here are some things that were harder. Here's what that means, and here's what we can do about it. And or you can just tie into something in the child's experience in a more organic way. Like if they come home from school and there's been some like contretemps with Billy because of XYZ that happened on the playground, and you're like, wow, you and Billy do get into these sort of situations a lot, and I wonder what could be, and so that it can be this sort of entry point to think about. Or you've said that X is harder for you, or that so-and-so is better at Y than you are, and guess what? That is a little harder for you. You're not wrong, and here's what we can do about it. You know what I mean? And so you can use either a certain event happening at a point in time, like an evaluation, or something from the child's own experience. And I mean, the more you can tie it into their own words and language and experience, I think the more powerful the experience will be for them. I had a little boy where he was 8, and the parents asked me to give feedback about an autism diagnosis. Really bright little guy, and parents were both sitting on the Zoom call too. And so I was sort of like, we're all sitting there and they're all staring at me. And so I sort of said to him, how are things going, and et cetera, et cetera. And he just gave me such a gift. He said, well, everything's going well, except I've been having some real problems making friends. And I was like, well, and so that gave me this entry point to talk about the many things he's good at and the fact that certain things are more difficult. And here's what we can do about it. I think it's important to have that message. This isn't like a terrible thing. This is just a thing. And here's what we can do to help you with any of the negative effects associated with it. Right. And there's that message of there are things we can do, and we're going to do them to help you.
I love talking to young children about how they think and learn. I know you said earlier that sometimes there is a lack of insight into certain situations. I also think they are so open to understanding. The young kids don't have necessarily the stigma that older individuals can develop over time, and they're more present, and using their words can be so helpful. And that's how I get kids into an evaluation to begin with. Parents often even ask, like, what do I say about getting them into your door to see you? And I say, use their words. How you said that it's hard to pay attention in class. How you said that math is really tough. How you said whatever it is. That's what we want to use to help them, because that's what they're feeling, and that's what we want to support them with.
This has been an excellent conversation. As we wrap up today, I'm wondering if you were talking to some parents who are just on the cusp of either beginning an evaluation process or have just received this feedback about their child having an ADHD diagnosis. What's the one piece of advice or the one thing that you would just really want them to hear, that you would really want to help them as they begin this journey?
One thing I would want them to understand is that, no matter what the findings are, no matter what, diagnosis may or may not be applied, what recommendations are made, your kid is still the same person they always were. I think parents are scared that it's going to change things in some way. It's more about trying to peel back the layers of what's actually already there. Do you know what I mean? And you're still the one who knows your kid best and who cares the most. And we're just here to try to help you help them, because that's really every parent's primary goal, is just to help their kids meet their goals and be content, productive little citizens, right? And that's what we're here for, to help with.
I think that's perfect. And I would just add that we want parents to take a step back and process information, that we give a lot of recommendations. I bet school gives a lot of recommendations. These are not all meant to be done tomorrow. There's a process. Take the time to think things through, ask questions. And really, it's so important for the parents to be educated and understand all the information that's being presented. They're the biggest part of this process. Like Dr. Fredriksen said, they know their child the best. They are the people who are going to be most helpful. So take a moment, it's important that parents' mental health is considered as well. We always talk about, and I'm sure everyone on your show has talked about, that you need to put on your oxygen mask first before putting on everyone else's. So take some time to take this all in.
Dr. Rothman and Dr. Fredriksen, thank you so much for your time today.
Thank you.
Thanks for having us. It's been fun.
When we talk about labeling kids, there's such a negative connotation to doing so. What if they feel confined by the diagnosis? What if they use the label as an excuse? Shouldn't we just focus on the individual rather than the label? And while I hear and understand each of these questions, the reality is that we use labels as a shorthand to get people what they need, whether that's accommodations at school, medication, therapy, or a greater sense of self-understanding. And for now, these labels are useful tools that we should access whenever we can. I'm Emily Kircher-Morris. I'll see you next time on the Neurodiversity Podcast.
I knew I was going to eventually have to use this music at the end of the podcast. It's one of my favorite pieces of all time, and I thought, why not today? Big thanks again to Drs. Rothman and Fredriksen. For more information, you can check out links in the show notes. Also, it's hard to overstate how helpful it is when you leave a positive review for us on Apple Podcasts or wherever you find us. We really do appreciate it. Our host is Emily Kircher-Morris. Our office manager and social media director is Krista Brown. I'm the executive producer, Dave Morris. For all of us, thank you for listening, and we'll see you next time. This is a service of the Neurodiversity Alliance.